Let's come back together. Is this working? Awesome. No, you're fine. Oh, and you showed me how the new clicker is working, and where did I put it? Thank you. Good, somebody saying that. All right, so I just realized I'm on page 8 out of 25. Yay, Rachel. Let's pick up the pace a little bit. How's that sound for you guys? Good. Let's go. It's so fascinating, though. We could talk about it all day. Well, I could. I find it fascinating. I hope you guys do. 2014 study diagnosing. Time and time I get asked, how do we diagnose this? A pediatrician can start to diagnose, can take a look. If it's clear-cut enough, they can diagnose. If not, we refer on to a FASD clinic. The U has one for adults, MOFAS has one for kids. This is probably hard to read, but you can look it up online and see it bigger and better. And it just says, what do we have going on? And it's this nice, beautiful flow chart. In case you haven't noticed, I'm a big fan of charts and graphs. Put it in a picture so I can get it. So it's this really clear-cut way for them to start to take a look at stuff. But we have to know mom drink. Clinical applications. Now I gave you all this data. What the heck are we supposed to do with it? Why is this important for us? You guys can watch the video in your own time, but the brain damage is irreversible. However, we can learn skills. That's where we step in. It's not a lost cause. I can't reverse brain damage. I can't force mom to stop drinking, but there are things we can do to help reduce the impact. Yeah?
A little bit back on the previous slide.
Go ahead.
So we have to know mom drank, which makes sense. But say it's one of those, like, someone drops the baby off in the hospital, so you have no way of knowing mom drank, and it's like very clear cut. Then what does that look like if you're trying to help that person? Like, if you can't possibly diagnose them, you didn't know that mom drank, what do they do?
It's a great question. If we can't know mom drank, what can we do? We do have in the DSM-5 now, and we're going to get into it in just a little bit, so thank you for that, neurodevelopmental delays that we can diagnose, and other things, other categories that can fall under. And Judge Wortnick is a FASD expert from Seattle, and he told me once, and I always get this wrong, so if it walks like a duck, talks like a duck, and quacks like a duck, I got it right this time. It's a duck. Whether somebody's telling me, yes, I'm slapping the label of a duck on there or not, it's a duck. I'm going to treat it like a duck. So if I see these things, how many of you guys, after going through the first half of today, are like, oh shoot, I think I've got a few undiagnosed on my caseload? Yeah. So maybe I can get that label put on, maybe I can't, but either way, it's a duck. Let's treat it like a duck. So, great question. Their frontal lobes are not developing normally. We can't expect this abstract, this reasoning that comes later in life to always develop during these times. Often found, if we're working with the family, the home environment's not always stable. What? We've never heard of unorganized home environments, have we? When we're looking at these cases, whether one, through birth, the situation's usually unstable in a lot of cases if mom's drinking, especially to the point where we're getting an FASD and pregnant. That's not likely to change. In adoptive environments, I gave a speech once at MOFAS, and families who had adopted kids with FASD came in, and it broke my heart, talking about the chaos that comes with adopting a child with these special needs, and all the love and support and effort and services that they're putting into it, but how much work it still is. So know that. And marriage and family is my background. If we take the kid or the adult and we cure them but put them back in the environment, how much work are we going to do for the long term? Children with FASD require 24/7 supervision. I worked with a mom who had a kid with an FASD, and he would have night terrors. I talk about this a lot when we do sleep, because there is a lot of sleep issues that come with this, and trauma, which contributes to sleep issues. When he had a night terror, he would literally run out of the apartment. She got locks. He got bigger. He could undo the locks. He wouldn't know what he was doing. Single mom, other kids in the house, how does she keep him safe? It gets to be very complicated. There's a lot of monitoring that comes in. And especially if we have mom having her own issues, or dad, whoever's involved, having their own issues, their own stressors, it can really complicate things. So very important to remember when working with these families that there's a lot going on behind the scenes, even in the best cases. We talked earlier when I talked about the book, Don't Look Me in the Eyes, rewards can be very few and far between. So these kids learn early on that life can be very discouraging. Their brain's not working the way they want it to. They're not living up to societal expectations or standards, so they can very easily become discouraged. And that can lead into some maladaptive behavior in adulthood, which a lot of us have probably seen. Frequently undetected and untreated. I've heard people say that it's the #1 cause of mental retardation or developmental delay. #1, we're just not catching it. I don't know if we're not catching it if we can really say #1, but a lot of experts believe it's the top. Have a very mature verbal ability, which results in additional difficulties because they can talk the talk. They can say they get it. They'll look you in the face and smile and say, yep, I get it, Rach, I'm good. No. Swiss cheese, it falls out, or they aren't able to translate it to the next environment. So many things that come into play. Very difficult to regulate. No matter how much repetition we might, how you self some skills, it might stick, it might not. So we might have to keep teaching the same thing over and over and over again. Because when we have an adult that doesn't know how to self-regulate, we've got problems. I work with a family, and I'll be brief because I'm trying to be quicker, but I work with a family where the son has FASD and autism, and moderately functioning, not really high functioning, and single mom who has severe physical disability and some pretty strong mental health disabilities, and then a 9-year-old sister. Well, he all of a sudden got big. He's 18 now, but all the way up until his 18th birthday, we'd have probably once or twice a year, probably twice a year, he would attack mom. He would get so angry he couldn't regulate. He would get so angry he would attack mom. One time he pushed and almost threw her so hard it literally broke her back. She has cracked vertebrae from the attack. The police were called to the house numerous times. I called every service I could possibly imagine. We got NAMI to give us a lockbox for the medications and for the knives and scissors. Not unheard of in FASD, again, in working with parents and families, locking up things that can be considered weapons. Everything we could possibly do to get this family help. And the police, by the time the police came, he was calm. They take him to the hospital for evaluation. He was calm. He'd be kind of through it. He'd say he was remorseful, and I believe he was. I believe he would just get so angry, and so did the mom. So she didn't want bad things to happen to him. She just wanted him to be under control. Because she believed he would just get so angry he didn't have control. He didn't know what he was doing. Well, one day, almost a year ago now, he turned 18. Exactly. Attacked mom in one of the mildest attacks that I've seen. It was so slight compared to some of the other stuff I've seen, but it was an attack. Nonetheless, I'm not excusing behavior. Police were called. Guess what? You're 18. We're taking you away in handcuffs. He was put in jail. Guess how well he functioned in jail? It was terrible. The police were calling. Case managers were calling saying, this kid doesn't belong here. But we can't put him back with mom because an automatic restraining order was put in place. Mom was saying, he's fine to come home. I want him home. They were saying, no, we can't put him in the home. She has no family that could take him. So they finally did find a family friend that would let him come in until we got all the stuff dropped, and now he's home. But it's kind of magical what can happen the day we turn 18, right? Society has different expectations. Even though his development is probably 9, say he's about 9, maybe 10. 2014 study looked at adolescents. They examined mental health, social skills. They found, so talking about the beliefs of what the adolescent, take this guy, what he thinks he could do versus what the caretaker thinks he could do. There's a significant difference between the teen's belief and their abilities versus the caregiver's belief. Themselves or the caregiver? I probably say it right there. The caregiver can't possibly do that. No way. I worked with a guy who was in his early 20s, because I only work 18 and up. He was probably like 20 when I started working with him, and he had autism, and we suspected FASD. We just weren't to the point of getting the official diagnosis because he was adopted. The mom, adoptive mom, bless her soul, she was doing absolutely everything she possibly could for this kid. Could not fathom him leaving the house until he could cook a dinner from scratch, organize the silverware drawer the way have it organized, have his dishes done completely every single day, make his bed every morning. Expectations? I don't do all that stuff. I thought, boy, I hope this very sweet woman never comes and sees my silverware drawer, because she's not going to be very happy. Certain expectations of what we want for our kids, we want the best, right? We want them to succeed and do really well, and we see their struggles, and it can be hard. And that's when I'm talking in the caregivers who truly have good motivations, and that's definitely not always the case, sadly, where the kids are like, you know, it's good. I can eat and, you know, I'll work at some small job part-time, and that's fine for me, where the caregiver is saying, no, they can't. So parents and caregivers tended to be harder on the teens than they were themselves. However, they did find in the study that both groups had an optimistic output of or view of the future. The parents and caregivers were harder on them right now, but both thought, you know, the future is going to be okay. They both had positive outlooks, so that was good. Areas of concern for these people? And there's positive view. Confabulation, what is it? I'd ask you, but I already told you. It's right up there. How familiar are you guys with confabulation? Somewhat? Yeah? Yeah?
Yeah.
Any thoughts on that, or?
I work with people that have, a lot of people that have brain injuries, issues. I see it a lot with, guys that maybe they don't remember everything, so they'll just kind of fill in the blank and just make up stuff and just not appear or stupid or, so I see it.
Absolutely, great point. With a lot of things where we're talking about different types of brain injuries, the brain has gaps of information. The brain wants to fill in those gaps of information. It is not malingering. It is not lying. It is honestly trying to remember, and the brain is mistaken information in the gaps. So there is a difference between confabulation and lying. It's a fine line, and it's hard to tell sometimes, but there's a difference. Yeah?
Where they're saying, like, no, honestly, like, the airplane came and picked me up in my yard and, took me. And they're like, no, it didn't. Like, yeah, yes, that's how I ended up overseas, just that whole piece of it.
Absolutely. The confabulation, delusions may be coming into some of this to play too, where it just gets really complicated. You're not going to convince them it's not true. There's a audio clip on YouTube, if you look up confabulation, where a guy's sitting in a psychiatrist's office and he's telling the psychiatrist, we're on a boat. I'm in the Navy. Well, let's look out the window. Well, there's water. You're sitting in a psychiatrist's office, but the brain is filling in information.
I'm just thinking of like pre-sentence investigations where there's always like this need to point out every inaccuracy that they can find. Like, well, he said this, but his past records show this, and a lot of times that's the only thing that the judge sees is this assumption that they're lying and that they're doing it deliberately to be manipulative or to get away with something. And I think it's probably a lot of times more this than deliberately this bad historians. Like,
yeah. I love how you said that, bad historians. Yep. They're not saying people don't lie to try to get out of stuff. They do. But we're talking about something different. When we have confabulation due to brain issues, it's inaccurate reporting of history. It's not trying to get out of trouble, And it can be really difficult to tell the difference between some of that. Very complicated in a group setting, very complicated for pre-sentence investigation and other things such as that. Yes?
You see this and other things too?
Yes, absolutely. Great question. You see this in other things besides FASD. Wernicke-Korsakoff syndrome, another thing that I train on, alcohol-induced dementia, TBI, other things where there's actual brain damage going on. You can see confabulation. Great question. Why is it important? There we talked about. Disorders where it's seen. Well, look at me jumping ahead of myself. There it is. There's two different kinds, provoked versus spontaneous. Spontaneous is due to the inability to remember the sequence of events. It happened, I just don't remember when. An example of that I read about was a guy who ran into a woman in the hospital. Oh, you're in the hospital, why are you here? I just had a baby. You know, I'm here because I had a baby. Well, she did 20 years ago. And she's in the hospital, and it triggered that memory of being in the hospital to have the baby. That wasn't why she was there that time. It happened, wrong time. And then provoked, a memory just created. I'm here because, I don't know, I can't even think of something right now, but just making something up unintentionally to create a reason to be in the hospital. Issues in education. Like I said, we talk a lot about teaching when these people are in the schools, but we don't just teach when we're young, do we? How much of our jobs is education? Big part of my job's education. How much are these people learning? How much are they able to learn? Intertwining to fit in. Let's talk about kids for a minute. We're in the school setting, and we have these kids. And the parents, I talked to you guys earlier about the mom who didn't want to get the son diagnosed with Asperger's because it might impact his ability to be a pilot or his other future choices. As parents, oftentimes we want our kids to fit in. We don't want them to stand out. We don't want them to be different. So sometimes parents, and I can get it, I get the psychology of where it comes from. We do whatever we can do to make our kids fit in. Orchestrating the school setting to keep up appearance, preventing failure. Thankfully, this mom that I was telling you about, the son is failing now, but the school wants to keep moving him through. So the school changed his grades to pass-fail so that it wouldn't look like he's failing. Yeah, I had all kinds of thoughts on that I'll keep to myself. But so the school changed his grades, and the mom was saying, fail him, please. Please fail my son. He doesn't get it. He's not learning. Keep him here. But oftentimes parents don't want their kids to fail. We want them to move on through. Get through, just get that diploma. Get the diploma, move through, get the job. Don't care if you get it or not, we're just gonna make you function. So I'm gonna do what I can do to orchestrate the setting so that you can function. Yeah?
I'm going to presenting as a good parent. I do CTSS, which is like arms for children.
Mm-hmm.
And I have a family, my identification is one of, or the middle of 5 kids that were adopted from bio mom to his uncles, and the uncle's wife is the one that raised them. But whenever they speak in public, she said, like, he tells me the memories, and she's like, they had ethnicity. They had ethnicity. That's what
Yeah.
it is.
Yeah.
It's not my problem. Like, acting like it's, she's a good parent, but they have ethnicity, so that's why they're acting like that.
Absolutely. Thank you for bringing up that point. That's a great point. It can be an affront on the parenting because the kids are not fitting in, they're not socializing, and, well, I'm a good parent. It's not me. Whether that brings out defensiveness or this ability to, or desire to kind of hide things or scoot things along through, whatever it is, it can be a personal affront on my testimony as a parent. And it's not. In some cases, sure. In other cases, you could be doing an A+ job. The mom with the son who just got out of jail that I was talking about beats herself up all the time. And I just say, you know what? She adopted him. I said if he grew up in the environment where he was, because she knew it was anyway, she knew the environment where he would have been, just think of where he would be. And that helps her a lot. Because she says, yeah, you know what? I don't want to say my son's on probation or my son gets violent or I have to lock up our knives, but think of where he could have been. So when you're able to process that more realistically, it makes a big difference for the kid and for the parent. So, thank you. Issues in employment. Talked a little bit about this earlier. So we're struggling all through school. Get out, society expects us to work, and we're going to struggle there, right? Not always, but in a very high percentage. Here's some reasons. You know, you look at some of this, I can't remember my schedule for the next week half the time. Thank goodness we have phones and other skills to help us. We all struggle in these areas. However, my brain's able to help me learn skills to cope with it, to figure it out. I know my strengths, I know my weaknesses, and I can work around it. Here we need some extra help, some extra support. How could you forget you're supposed to work Tuesday? You work every Tuesday at 9 o'clock. Well, maybe it's a gap of information.
A lot with, selling drugs. Well, I can't keep a job, but this I can do whenever I need to, or whenever I know, okay,
Absolutely. Selling drugs is easier. It's more convenient. I don't have to fit a schedule. I don't have to do a certain thing. They call me and I have to go do this now. Pawning things, see a lot of pawning things, this inability to budget. But I know right now I can get $100 for this. So in the moment, very moment thinking. Thank you. Issues in adulthood, they continue. A recent study looked at adults with FASD to find the impact in adulthood. They were around the age of 32. So here's some newer statistics. Special education, the people with FASD, 25% versus the average of 2. Half were unemployed versus the average of 15. 31% disabled. Hospitalization for alcohol use. I thought that was an interesting one. 9% versus 2% for the general population. Psychiatric disorders, 30%. Prescribed drugs. However, interestingly enough, the level of criminal offenses was similar. I found that very interesting. And again, I think speaks in large volumes of the amount of times this is not diagnosed. And we're not fully catching the scope of the issue. FASD and autism, you've heard me kind of talk about them similarly today. They're not the same thing by any means. I'm not trying to come across that way, but there's a lot of similar issues. And I think you saw that in the beginning, where there can be some crossover in issues and sometimes a co-diagnosis. So they looked at it to see similarities. They found a lot of them. But children with FASD were scored lower than their peers on social functioning and higher in behavioral concerns. So they're having trouble making friends and they're behaving. They're acting out more. In autism subscale, they scored higher in social communication, but lower in repetitive and restrictive behaviors. So lots of similarities, some differences. Important to keep in mind because, again, speaking to society's bias, we know a lot more about autism. If you start looking at research on autism versus FASD versus some of these other disorders, there's a lot more out there. All right. Other deficits may include motor control issues, clumsiness. It may give the appearance that they're drunk. They might not have that, smooth gait, the other things. So it might appear that they're drunk. Something to watch out for when you're working with FASD. Cognitive deficits, increase in delinquent type behaviors, lack of regard for pro-social behaviors, and diminished ability to respect limits and rules. Again, speaking to not understanding the consequences of our actions. I might have less regard if I didn't understand the consequences. 1, have the empathy to know what it might do to the victim. 2, know what might happen to me if I perform this certain action. Other strategies, using memory aids. We talked about that a little bit. Schedules, organizers, schedule consistency, maintaining appropriate boundaries. I have a quick funny story about boundaries. So we have a nice group here, right? Let's say, well, we had donuts, but let's say I brought in pizza because that's what I did for my FASD groups. I would bring in pizza. I have a stack of pizzas that looks about appropriate for this room. How many pieces, Little Caesars, so the big triangles, how many pieces would you grab when you go up? 1, right? Pretty societally standard. This was my fault. I messed up. I didn't say that because I think I bring in pizzas to a group, everybody grabs 1 to 2. My sweet individuals with FASD, more than one of them were going up and piling up their plates. So I didn't think the social boundaries, these social norms that we think about. I had to walk through, and there was a woman in the room who knew a lot about FASD who thought it was very funny. I didn't think to do that, and I get where she thought it was funny because it ended up being kind of comical. The next weeks I had to say 2 pieces. And then when we're done, I'll make an announcement that everybody's done, and if you want more, then you can go grab 2 more. And then you can have whatever's left after everybody can grab 2 more. Outlining these basic social norms because they don't know. And they were very hungry and it was free. So I had to do the same with soda because they'd grab the whole 2-liter bottle and bring it to their plate. It was very endearing. Nope, I brought cups. All right. I'm going to talk about this briefly because we could go into this for an hour. They are coming out. The trouble with FASD and the trouble with getting a diagnosis is physicians have always said it's a mental health thing and mental health is said as a physician's thing. Where do we find that line to come together? Because it's really both to get this diagnosed, and who should diagnose it and how? How easy should it be? So in DSM-5, we are coming out with this neurobehavioral disorder associated with prenatal alcohol exposure. So this is in the area for looking at these different things that are coming, how it's impacting the so we're getting there. Jared Brown and myself have talked to a lot of different professionals on this. Have you looked at this? Are you comfortable diagnosing this? What does this mean? How do we diagnose it? Everyone's just kind of throwing their hands up in the air. We don't know. Think of some of these diagnoses now that are so concrete for us and so easy back when they first came out. It's murky waters. We're afraid to navigate it. So did I put it in here or do I need to talk about it? Okay, it is in here. You could really open it up for debate, I think. There is in the DSM one small line in one small section under other specified neurodevelopmental disorder. Here's exactly what it says from the DSM. Characterized by a range of developmental disabilities following exposure to alcohol in utero. So I can diagnose neurodevelopmental disorder based on prenatal alcohol exposure. As a master's level practitioner, though, am I comfortable doing that? No, personally I'm not. Maybe some are, it's in there, but I think that's taken a pretty big jump. Because mom can drink, mom can binge drink, and there can be almost no impact. It's a gamble, like we said earlier, we don't know. Just really quick, I'll open it up for a minute. What are you guys' thoughts on, you guys again, here I go. What are you guys, what is you guys' thoughts?
I really, I think if the mother is hard to get them to honestly admit that they drank or how much they drank. And sometimes because of the shame, they are poor historians. And will well, I did have a drink at so-and-so's wedding, but, and I got drunk once, but I realize that it's very prevalent, especially the last couple generations during pregnancies. And there's really no, I don't know, so many people get misdiagnosed. I was hoping that whenever you suspect it, because you can't always trust parents, or if you have thought that could prove it.
Yeah.
All school for kids, I think you know your brain scans so we can deal with them
There is.
appropriately.
Yes, absolutely. If we
Realistic
could.
expectations.
That's a great point. With that brain scan, I might be a lot more likely. When I'm looking at an FASD clinic and how they're diagnosing, they're looking at mental health, behavioral, learning, facial features, speech and language patterns. These very thorough tests that, like you said, I wish we could have, that I could do just easily as a master practitioner and say, okay, yep, you know what, I know that you have it because I have these magic tests. I don't have that right now.
But what about what you said earlier about the duck story?
The duck story, absolutely, absolutely.
You've got the power to actually make some substantial changes in opening this up. I'm kind of unclear about what your fear is.
That's a great point. I did say earlier, it's a duck. Me treating in the way it's appropriate for somebody with this kind of brain damage, to me, and I could be wrong, you guys could have a very different opinion, but to me it's very different than me documenting that this is directly related to alcohol. If I'm treating it like this way, I'm suspecting there's something going on with the brain that's creating these issues. I might think it's alcohol, but is that my bias because I know a lot about FASD? Could it be something else? I fully admit it could be my bias because I work a lot with this. It could be something else. If I'm putting it in documentation, it's creating a written correlation that I don't know if I'm comfortable making.
But doesn't that say not reach another disorder?
It does. Not reach full criteria for another disorder, without a doubt. You're right. DSM-5 doesn't do rule-outs. Otherwise, yes, I would feel comfortable with a rule-out. I do feel comfortable in my comment section, further testing to explore, or maybe unspecified, but specified is hard. Yeah.
Think about the way that the specifier is a secondary issue and is actually fairly irrelevant, except when you're dealing with the minutiae of treatment.
Yes.
If you get the neurodevelopmental NOS, and you get that down in documentation, and then you've got that to show for Title I and Title III of ADA, you've got that for educational accommodations, work accommodations. Depending on how much history you've got, you can get into county labor services if you can show it before 18. So I mean, really the specifier is kind of irrelevant for the real life impact.
Yeah.
For trying to fit in. So that's actually a really good thing. So just pointing out that piece, as long as it's in there, it still helps those of us who are trying to help get along.
Great point, absolutely. I can say that there's issues that are impacting this person's ability to get by in work, home, other environments. I can demonstrate that. Whether I can point to a causal relation, I would think that I could, and maybe a lot of you guys are very comfortable. Like I said, it is in there, but am I personally comfortable? I don't know. I'd have to know more about it. But the important thing is pointing out that there is something going on that's impacting functioning, and as you said, in how I'm intervening with this individual. What am I doing as far as treatment, and how is that impacted? Yeah.
Well, and I think too, empowering them to know that, I find a lot of guys, they just want to be like, what if, just give me the name. And it's like, well, maybe it's not just one specific thing, it's just looking at the actual struggles that you're having and what areas you need to work with versus just give me the diagnosis, give me the med, and let me go on my way. And you don't realize that it's not, what's the name going to give you? Okay, so if you have schizophrenia, what's that going to do for you? Does that help you manage your emotions and everything better because you know it, or is it better to focus on what the actual problem is that you're having and getting them to be okay with that?
It's a great point. There can be individuals a lot of power in a diagnosis and a label. It can be very empowering and a very positive thing. For other people, it can be a very negative thing. A lot of people I know, mental health, just firmly don't believe in diagnosing. Let's just treat the issues coming in life. What good does it do to slap this label on it? Well, there can be, as you mentioned too, for waiver services and other things going on, employment accommodations, things like that. But for some people, is it always necessary? I don't know. My point is, it's gray. It's murky. It's up to you. Do your research, just know it's there. Homelessness? All these different reasons why people with FASD are prone to homelessness. I think with what we've talked about today, it just makes sense. Oops. potential implications, landlord problems, issues in paying rent, locating housing. How many of you have worked with people to try to help them find housing? It's exhausting. It is so complicated. Throw a criminal background in there. Holy cow. Throw on Social Security. It's so difficult for us. And I'm going to make a big assumption here, but I think we're all pretty smart people, right? It's very difficult. Take somebody who's lower functioning, who needs some help. It's really hard. I'm working with a guy right now who I suspect there's something going on, but I'm not quite sure what. But he has a lot of paranoia, and it got him just about kicked out of his apartment twice now in the last month. And he's alone. It's just him. He's got a brother that he doesn't really talk to. Parents are gone. He has no friends, no social network. And so he sits there and it gets built up in his head. And pretty soon their comments come across as really strong personal assaults. So he had called legal aid, the landlord people, what's that called? Where you, landlord rights or whatever? The landlord rights people. These people are coming at me, and when I took a look at it with him and really broke it down, they were just trying to get in his apartment because he had bed bugs. They had a right to do that, right? They have an absolute right. But it can be very difficult for people between their mental health or neurodevelopmental delay to understand some of that. So having somebody there with them to help navigate those waters, we were able to let them in. I was able to walk them through that. We were there together. I helped intervene with the communication with the landlord because he was getting very escalated and he was coming across pretty angry. So to help calm things down for them, let's take a look at it this way. That's why a multi-pronged team approach can be really beneficial. Interventions, help them with some of this stuff. In employment, they might need some support. The Workforce Center does some of that. There's other people that can do some of that. I tell them, yeah, you worked before, but now you can talk to me once a week and we can process some of this stuff. Some of the stress you have going on at work, and maybe that'll help. It sure helped in the guy with the landlord thing. It helps with his work too. He can come and say, can you believe this person said this to me? Well, let's take a look at their motivation. Let's talk more about this. A lot of people I know that I've worked with, they try to go to college and it doesn't work. They don't know that there's accommodations that we can get, that there's steps we can go through to get them help. They need someone to help navigate that with them. In-home, and I love it. I think that most of the time. You've been in those homes. I think that there's some guardian intervention is needed. If the there's case management or other services in place. Jared Brown, I talked about him earlier. They're more likely to get special education, be unemployed, disability funds, alcohol abuse. Some evidence that their rates of crime are higher in this population in North America. Does that surprise anybody with what we've talked about today? No. Correctional settings, more quotes I'll let you read from Jared. He writes about this a lot. So here's a research study of the contribution of FASD to crime rates. Legal interventions do not result in reduced crime rates for subpopulations. Substance use, domestic violence, child abuse, mental illness, and FASD is part of all of that. These are the populations we're seeing time and time again. They're the ones where our interventions just aren't working all the time at this point. Can contribute to some of that. Yeah?
That, like, building sympathy for people with FASD or other disabilities. The problem is that if they have these disabilities and they get into the criminal justice system, then none of the programs that would normally help the disabled person are willing to still help the criminal.
Yeah.
And so, like, I mean, I've had cases where, you know, you can't find it. I mean, they need supportive housing, they need places like that, and like, oh, they've got this assault on their history, we can't let them in because we have vulnerable people. And so you try and argue that they're vulnerable too, but there's just no resources for them that are willing to chance, like the mom will let them coming back. These other places aren't there, and so the prisons and jails kind of just become the fun because they'll take them. And it's really sad, frustrating, because I know that they would benefit from all of the services that they get because they do have the disability, but people kind of put blinders on it and forget about that and focus on the criminal side too much.
Yes. I don't have much more to say except yes, you're absolutely right. We have this soft spot and this warm, fuzzy place and this desire to help people with developmental delays, I think. That's why we're in this room, right? That's why we're in this field. We want to help. Throw the criminal record in there, it just makes it harder. For us personally, you know, in my trainings, I talk a lot on forensic stuff, and I always say I am not trying to come across as excusing criminal behavior. I'm not. It's wrong. We have a society where we need to find ways to reduce it. What I'm trying to do is help people understand the motivation, hoping to reduce recidivism through ways, because natural consequences isn't always going to work. So let's get these people out in society. Let's say they want to try again. Society's not always designed that way. Take a sex offender. It's really hard to make violence convictions. It's very difficult, and I get that. We have to protect our vulnerable populations. But then what do we do with these individuals? How do we help? Yeah.
Basic ISR stuff. They violate right away and then they're just right back into the system.
They violate right away, and
It's just inevitable. They're setting them up.
yeah, they give up because they're too frustrated. Maybe they're more comfortable. I talked about it earlier, more comfortable back in jail. I worked with a guy for a long time, and actually now he has a full-time job, so he can't use me anymore. Yay. But we worked for a long time, and he was in this cycle of, he was trying. I was trying with him. This is when I was doing ARMS. We filled out job application after job application and housing and all this stuff, and he had 7 theft felonies. Everyone turned him away. Well, it was from a 1-year kind of crime spree with this meth group that he was involved in. He was very heavily using meth. He was very eager to make friends. And so he did a lot of the activities for them and got in a lot of trouble. Well, he was trying really hard to start over. And I was trying really hard to help him. Turned down, turned down, turned down. I don't think it's a surprise. He went back to that group, started getting in trouble again, tried again to get back out. Well, this time they decided to throw the book at him, I guess is the best way to say it, which he did a lot of wrong things. So he says, Rachel, I'm going to go away this time. I give up. I've tried so hard to start a new life, and nobody's willing to give me another chance. So screw it. I'm going to go away, and I'm going to become the best goddamn criminal you've ever seen. Pardon the language, but it's what he said to me. He tried the other way. It wasn't working. Criminality's working for him. He went away. He came out. He did call me right away. We worked together for a little bit, and then he found full-time employment that's a little sketchy, but it's full-time employment. So I haven't heard anything else. But yeah, talk about haunting. Having somebody say that to you. He was frustrated. He gave up. Much is known about the causes and consequences, although it's rarely implemented in practice in the criminal justice system. We talk about it, we know. As a group here, I think we have a pretty basic understanding of why this happens and how it can come into play. However, it's really tough to get judges and juries and other people to understand that. Victim impact, other things like that can be really complex when you're talking about FASD. Implication, mental illness is found in, well, this study found 90, but over 90%. Similar to ADHD with its impulsivity. They're not thinking before they act. They're acting before they think, and that oftentimes gets them in trouble. Failure to attend court, comply with conditions of release. You were talking about that. We're sending them out. They can't comply with what we're setting up, with these rules of probation and other things that we as a society need for them to seem rehabilitated and to stay out of trouble. FAE, fetal alcohol effects, has a poorer prognosis than FAS due to the invisible nature. Again, talking about if we can see it, we work with them a little more. We try to get them more services than if we can't see it. just a bias in society, which makes sense. Another study, physical, cognitive, and behavioral with FASD, likely to impair the ability to successfully navigate interrogation, trial process, just the Miranda rights. There's many studies on the Miranda rights and how complex that is. I think we all watch enough TV where we can sit and recite our Miranda rights, at least the beginning, right? What does it really mean? Do we know? Especially if we have a developmental delay. Do we understand what incriminating ourselves means? Do we understand what we have to do when a police comes? That's scary. Do we know what to do? 90% of young offenders had impaired legal abilities when we look at FASD, which was significantly higher than people without. FASD group had significantly different scores on the fitness interview test. It's important to intervene in a legal setting because they're walking the walk and talking the talk and looking like they can do it, but they don't get it. It's not sinking in, they're not understanding. Unique needs for those undergoing criminal prosecution, and the word is getting out there. We are spreading education and awareness. It's not like it was back in the 70s where we're just trying to get this out there. There are advocates, there are disability services, waiver services, we're there to help. We're just not quite there where we're reaching most of the population yet. Reading through the rest quickly, 10 to 23% of those seen in a criminal justice setting are estimated to have FASD. Do you believe that statistic, 10 to 23%?
In this study, because there's so many people.
Absolutely. Those that are diagnosed that we're catching, yeah. Adolescents, their brains aren't fully developed anyways. They're impulsive. They're egocentric. All these things that can contribute and then exacerbate the symptoms of FASD, creating a higher likelihood of them getting in trouble. So what do we do about it? Difficulties understanding the Miranda rights, a skill set needed for the adjudication process, whereas others did not. Whenever we talk to people with FASD, we talk about having a card in your wallet. It says, my name is Rachel TD and I have FASD. I don't, but if I did, having that in my wallet so that if I do get arrested or I get pulled over or I get into some kind of trouble, pull that card out and that card says call so-and-so at this phone number. That way we have some kind of intervention to say, here I'm letting you know I don't really have the ability to understand what you're saying. Can you please call somebody so that I understand what's going on? Explain key facts, use simple language, repeating information, one-step directions. How many of you guys have kids? A lot of you? Can you say to your kids, especially when they were young, go upstairs, put your socks on, make your bed, close the drawer, brush your teeth, and come down and eat breakfast? What? She said something about socks. I'll go look at socks, but then I'm distracted by the TV over there or whatever, right? Simple, one-step directions. Yes?
I just feel a need to talk about the card.
Yeah.
To be able to get you to like some people that you're working with. Is there a way to preface that so that the person that wants to give the police their card can explain that to somebody? So in other words, if they start to fumble around in their pockets, that's going to be triggering police. They're not going to know what they're fumbling for. Especially if it's in a back pocket. It looks like you go for a weapon. So, that could have some unattended.
Or maybe a medical bracelet.
Ah, great. Medical bracelet? That's a very good point. Excellent, excellent. Thank you so much for bringing that up. Without a doubt, I have a card in my wallet that explains I have a disability, educating the individual. Also, whenever we talk about DD, especially with children, it doesn't hurt to let them get to know the police. Know that we have so-and-so in our neighborhood who has FASD or who has autism. The police know now the young gentleman that I was telling you about earlier, because the more they know them, the more they'll know what's going on, and that making sure the individual knows to be very clear and saying, don't fight the police, don't look like you're reaching for something, Explain that you have a card, you need help. Can I show you this? It's in my wallet. So, thank you so much for saying that. All right, more about what's wrong with criminal justice system. They can be misunderstood in courts. You said earlier, victimized in jails. Absolutely, absolutely. All right, so what do? I said give one command at a time. Don't ask complex and multiple questions at a time. We can't always expect abstract reasoning with any population. Yeah, we'd like to think everybody has it, but it's not always there. Guilt, remorse, the ability to show thinking and feeling at the same time, to really be able to feel what they're experiencing. Consistently explain the rules and regulations. They might forget. Have it in writing, have it somewhere written down. Maybe incapable of self-regulation. Remembering that in a prison setting is very important, because when they get escalated, it could be dangerous, and we need to keep people safe, including the individual. Frequent lapses in emotional behavioral control are expected. And the biggest thing is, yeah, we can't say it's okay, because we can't have that in these settings, but no, it's not willful. Know that the person is probably doing their best, and maybe it is willful at times, but knowing the difference. Maybe at elevated risk of exploitation as well. She mentioned that earlier too. Exploitation, victimization. And that doesn't end because they're in prison. Sensory integration problems, overstimulated by various aspects of a prison environment. I've been in the prison environments to teach, not to be there. You guys were wondering, I know. It's overwhelming. It's confusing. There's rules and regulations, and you have to be here, and there's lots of people and lots of noises, and that can be very overwhelming and anxiety producing for an individual with FASD. Not likely to recognize other inmates' personal space and boundaries. We talked about personal space and boundaries a lot earlier. How much is that going to impact somebody who's in a prison environment? You're in tight quarters with a lot of people who aren't always very patient with you. Accept blame for legal activities they did not commit. Sure, I did it. Whether it be confabulation, the ability to make friends, wanting to please the officer. I see a lot of wanting to please the officer. Increased likelihood to provide correctional staff with incorrect information, and knowing what the motivation is behind that. Profound memory deficits, which is an issue if we're wanting them or wanting them to remember where they have to be at a certain time, if they have involved in that. A lack of ability to manage stressful situations, which happen often. Again, making it very difficult. Sounds like they know what and easily distractible. All big problems in a prison setting. Inappropriate and unwanted sexual encounters. We talked about the inappropriate sexualness and then how these other factors come into play. That doesn't end because you're in prison. Host of other challenges. Monitored for committing self-injurious behaviors. High rates of self-injurious behavior, so something to be monitoring for, especially in these settings. Targeted by other inmates upon re-entry into the community. More likely to engage in recidivism for all the hosts about today. So what early diagnosis enough. The earlier we know, when you're looking at education, mental health, developmental delays, anything like this, the earlier we know, the more we can intervene, the more likely we are to be successful. Catching it, like we catch us catching this autism in this guy in his mid-60s, it's pretty hard for him to learn some new autism-based skills, because he's been doing it this way for 65 years. And who are you, young Rachel, coming in trying to tell me a new way to do it, right? It can be very difficult. Case management, multi-pronged approach. You can't do it alone. You will burn yourself out in a very short time. Don't try to do it alone. Developmental disability services, as early as possible and as long as possible. Structure, supervision, supportive caregivers. Are they capable of living independently? What's prohibiting them from living independently? Do they need staff, ILS, PCA? Do they need to be in an adult foster care setting in some more extreme settings or more extreme cases? Things like this, putting them into place so that we're not setting them up to fail. We want to set them up to succeed. So let's do the least restrictive environment, but making sure we're giving enough support for them to get by. No exposure to antisocial peers. Oh good, I'll wave my Rachel magic wand and say, you aren't gonna hang out with anybody who's antisocial. I'll cure the world, right? Try to encourage, know the difference, understand the impact and how it can help or impact that individual differently than it might you or I, who has the ability to understand the potential consequences, how they might use me as a scapegoat and things like that. Medication, I'm not going to talk much about medication because I'm not a psychiatrist, but are they on meds? Do they know what meds they're on? Are they taking them? Are they effective? Do we know why? What side effects? Helping them explore things like that. If they don't know, finding somebody, a service person who can come with them to psychiatry appointments so that we help understand. Targeted skills training, they can't manage money, well let's just take a look at money. FASD or not, let's try to find a way that works for you to manage your money or your impulse control or whatever it might be. There has been found some effectiveness with DBT. So keep in mind. Anybody here trying DBT? Okay. Mindfulness. This is one where it gets a little sketchy. Some people say mindfulness will absolutely not work with FASD because we don't have the cognitive abilities to do that. What I think and what I believe and what research will back up is that it's a spectrum. Like I said in the beginning, we can never say all or never for any individual or any disability. Some do have the abilities and they can have the mindfulness. It might not be as natural as it is for me and you. It might have to be more coached, taught, trained. But we actually work with the mindfulness expert quite a bit at APHIS, and he talks in our FASD talks about how it can work. We can do mindfulness training with these individuals. Neurofeedback, attention awareness training, and assessment for specific comorbidities. If we have an attachment disorder, let's look specifically at that. Not everything has to revolve specifically around the FASD. The mom I was talking about earlier with the son who has FASD and autism, when she's looking at parenting, she's looking at a behavior that he's doing and she's asking herself and me, is it more the FASD or is it more the autism that's creating this? I can't tell which one's doing it. I don't know. I can't say, but let's treat the behavior. And if it's not working in this way, let's find a new way to treat the behavior. Because if we try to bring everything back to the FASD, it might just be too complicated and it might not be as effective as if we're working skill by skill. Write down homework. We talked about single step directions. Write down homework. If I want this person to do a journal entry for me each day, or I want them to talk to their psychiatrist before our next appointment, whatever I might want them to do from meeting to meeting, make sure I'm writing it down. How many of you guys leave the doctor's office or whoever's office and they tell you to do something and you walk out the door and it's gone? Or you remember it for that day and then that you go back the next week? Shoot, I didn't do that. It's hard for all of us, especially with this population, so make sure we get something concrete. Insight can be difficult. I know we're all very highly intelligent people. Is insight-based therapy a fit for everybody? No. It might be a fit for 80% of you. 20%, you might not have the insight, you might not want the insight, you might not be ready. So court-ordered therapy and other things, I'm in some cases right now where I'm there because I have to be there. The person doesn't want therapy. They don't know why I'm there. They don't have the ability. In these cases I have right now, they really don't have the ability to process in that way, to think. It's a waste of everyone's time. It's wonderful. We can sit and talk about fishing or whatever they want to talk about. I could try to bring stories, bring some insight to it, but it's not for everyone. You can't force insight on people. Information may be present one day and not the other, and that goes along with confabulation. Remembering it's not willful. It's not mindful. It's just stuff that their brain is doing as coping strategies to get them through. Psychoeducation for the family, caregivers, and staff. Again, my bias.